Good afternoon, at least for those of us on the East Coast. I know we have over 400 people registered, so I'm sure some of you, it's still morning, so thank you for joining us. My name is Kamala Allen, and I have the privilege of being CHCS's Senior Vice President for Program and Strategic Planning. It's my particular pleasure today to be with you serving in my role as Director of our Child Health Quality Portfolio, in which the work you're going to hear about today sits. Just want to start off by saying a quick thank you to Emily Gold and Brandon Petit-Home, who are our colleagues on the communication side of the house who are supporting us today. So let's get to a little bit of context for what we're doing today. We know everybody is busy. Again, thank you for joining us. You're here to hear more about opportunities for primary care to support efforts to avoid the unnecessary involvement of families in the child welfare system. Before we get into that content, we want to acknowledge our funder, the Conrad and Hilton Foundation, for supporting this important work. The foundation's investments focus on improving the lives of individuals living in poverty and experiencing disadvantage throughout the world. We're honored to have been a recipient of foundation funding for several years. Our work with the foundation was initially focused on prevention and early identification of substance use in adolescents, and most recently, as you'll hear about today, on preventing families' involvement with the child welfare system. Also want to acknowledge just a few people who made this work possible. Our current Hilton Foundation Program Officer, Mr. James McClellan, we want to say thank you to him. Our former project officer, Alexa Eggleston, who initially funded this work, and Senior Advisor, Dr. Kima Joy Taylor. So thank you to each of those individuals. Next slide, please. So I want to jump just really quickly, let's go one more, into our Q&A for today, because we know that's really where you're going to have the opportunity to engage with our presenters. Most of you are probably more familiar with Zoom at this point than you ever wanted to be, but just in case it's new to anyone, and depending on the version of Zoom you have, you should see a toolbar at the bottom of your Zoom window that gives you the option to enter into the Q&A panel. In our version of Zoom, it's to the right of the chat button. In yours, it may be to the left, but it should be somewhere near your chat button. Please note that we have disabled the chat so that we don't create any distraction for our presenters on today's webinar. To ask a question, simply click on that Q&A button, and you can respond or submit questions through that Q&A feature throughout the entire webinar. Don't hold till the end. As questions come to you, feel free to submit them throughout the webinar. Just want to note that if we have a number of questions that are similar, Olivia and Kelsey are going to be monitoring the chat when they're not presenting, and will identify questions that kind of get at a theme of a group of questions. So while your specific question may not be answered, we're going to do our best to make sure that we get to all of the categories of questions or orientation of questions that come through. And any that we're unable to get to, we will do our best to answer following the webinar. So with that out of the way, I'm going to move on to the agenda for this hour and introduce those of you who are new to CHCS, to our organization, and to this project. So I just quickly covered our welcome and introductions. I want to introduce my colleagues who are going to be at the reins for our webinar today. I mentioned Kelsey Breichman, who is Senior Program Officer on our Delivery System and Payment Reform team. Also would like to introduce Olivia Randy, who's a Program Officer on the Child Health Quality team with me. We have some other staff who have really contributed in a meaningful way to this project and to the paper that's soon to be released. So I want to also acknowledge Rob Houston, who's the director of our Delivery System and Payment Reform team, and two now former CHCSers, Stephanie Arbutina and Isabel Clemente. So just want to say thank you to them for their contributions. The webinar today is really going to focus on sharing the findings and policy recommendations that come out of the work that we've been doing for the past year and a half. We'll have a really exciting discussion with a panel of individuals who are really esteemed in their respective fields and bring a particularly insightful perspective to the topic today. That panel will be followed by the Q&A, which, as I mentioned, we will conduct through the Zoom Q&A feature. My last task before moving aside from my colleagues and our panelists is to provide a quick overview of what CHCS is and some background on the project that produced the findings you're going to hear about today. So the Center for Healthcare Strategies is a nonprofit, nonpartisan organization based in New Jersey. We are, I think, approaching our 30th our birthday. CHCS works with stakeholders both locally and nationally to strengthen healthcare services with a goal of ensuring better and more equitable outcomes, particularly for children and adults served by Medicaid. Since 1995, we worked in every state in the nation in partnership with state and federal agencies, health plans, providers, community-based organizations, community-based, consumer-based and consumer-run organizations, and individual consumers, all with the goal of making healthcare work better for people who face barriers to well-being. Barriers like poverty, complex health and social needs, and systemic racism. CHCS has 3 priorities we work to advance: creating more effective models for care delivery, more effective policy and program design across all of our work, regardless of the programmatic portfolio. And our work today is an example of a project where we are working across portfolios to bring expertise and perspectives from both our child health quality team and our delivery system and payment reform team. And then lastly, more equitable care and opportunities to address the obstacles that stand in the way of health equity for people who face the greatest disparities. As that relates to the work you're going to hear about today, I want to identify more effective, this effort to identify more effective approaches is really critical because we know that families who are at risk for child welfare involvement often face incredible obstacles in terms of social economic prospects. They have higher health and social needs, early relational health needs, behavioral health needs, both of the children and of the caregivers. These families often have difficulty accessing high quality coordinated care. And specifically for families of color, there's an added burden of being disproportionately impacted by racist and discriminatory practices, including being more likely to be reported to Child Protective Services. So on the next slide, I want to highlight just 3 points as it relates to the project, and then I'm going to turn it to my colleague, Olivia. Our hopes with this project were really to more clearly define the role that primary care can play, recognizing that we ask a lot of our primary care practices and practitioners. Also to identify challenges that might be barriers to them playing that role and proposing some approaches that might mitigate these challenges. And finally, to tie all of that back and look at how Medicaid can be a financing mechanism to support those approaches. We listed a number of strategies to do this, including conducting a national scan of the literature, talking to experts in the fields of child welfare, primary care, pediatrics, healthcare financing, and research. And what you'll hear in the time that remains today emerges from that work. So we're extremely grateful to everyone who participated at any point in this project. And while we don't have time today to acknowledge all of those individuals, they will be acknowledged in the final paper that's pending publication within the next month. So with that, I'll stop and I'm going to turn it over to my colleague, Olivia Randy, to present our findings and recommendations. Olivia.
Thank you, Kamala, and hi, everyone. Thanks for joining us for this webinar. As Kamala mentioned, my name is Olivia Randy, and I'm a program officer on the Child Health Quality team here at the Center for Healthcare Strategies. And I'm just going to talk through some of the findings from the project that Kamala just described, including strategies for primary care practices, as well as recommendations for state Medicaid agencies to support primary care. So I'm going to start off with just some background information. In recent years, the child welfare system has shifted priorities toward preventing out-of-home placement, including entry into foster care. And there has been a decline in the rate of children entering foster care. One important policy change is through the Families First Prevention Services Act of 2018. And this act allows child welfare agencies to provide services to families that are intended to prevent out-of-home placement. So these services include mental health services and substance use services, in-home parent skill-based services, and kinship navigation services to help relatives such as grandparents who are raising children access services. Despite these changes, over 200,000 children enter foster care each year in the US. And because of systemic racism and discrimination, Black and Indigenous families are disproportionately overreported to Child Protective Services, or CPS, and they're overrepresented in foster care. The most common factor that contributes to children's placement in foster care is neglect, which is the failure to provide adequate food, clothing, shelter, or care. And because of that definition, neglect is strongly associated with poverty. And so one reason that Black and Indigenous families are overrepresented in the child welfare system is because systemic racism and discrimination have led to higher poverty rates among these families. And in some cases, the circumstances of poverty might contribute to neglect, while in other cases, these circumstances might be inappropriately equated with neglect because of misperceptions or biases. And bias also contributes to the overrepresentation of families with disabilities, as well as families of youth who identify as LGBTQ+ or another identity in the child welfare system. So while child welfare agencies can now provide services to prevent child welfare system involvement, other health and health-related systems can also provide many of these services. And pediatric primary care practices in particular can play a key role in this because they're such a critical connection point between families and the healthcare system, and because they're already largely focused on prevention and upstream intervention. It's also important to note that while anyone can report a case of suspected child maltreatment to CPS, healthcare providers are mandated reporters, which means that they're required to report cases of suspected child maltreatment to CPS. Finally, Medicaid is an important source of coverage for children, including children of color and those who are at risk of involvement with the child welfare system. And so Medicaid can play an important role in supporting primary care efforts to help prevent child welfare system involvement. Next slide, please. So this slide covers opportunities for pediatric primary care practices to help prevent child welfare system involvement. So that includes providing more comprehensive care and preventing unwarranted reporting to CPS. And first, primary care practices can integrate medical, behavioral health, and social services to help address families' needs. So this can help to prevent child welfare system involvement by addressing risk factors associated with child maltreatment, including behavioral health needs, health-related social needs, and relational health risks, such as adverse childhood experiences. Second, primary care practices can support relational health, which focuses on the role of relationships in child development, and particularly relationships between children and their caregivers. And relational health can be supported by dyadic care approaches that consider the health and well-being of the child and their family, their caregiver together. And these approaches can help families to build protective factors such as parental resilience, which can help to prevent child welfare system involvement. Importantly, as primary care practices identify and address these needs and support relational health, it's important to ensure that in doing so, they avoid unintentionally increasing reporting to CPS. So this includes acknowledging biases and focusing on family-centered care, as well as developing a strong understanding of mandated reporting laws. Next slide, please. So this slide continues from the previous slide. So the third opportunity we found was for primary care practices to implement anti-racist policies and practices. So this might include providing training on implicit bias and cultural humility, and recruiting primary care staff who share common racial and cultural backgrounds as the families they serve. Primary care practices can also provide training and education for staff about the history of the child welfare system and inequities in the system, as well as racism and systemic racism more broadly. Lastly, primary care practices can build partnerships with families and provide family-centered care. And these partnerships can help to build trust and improve care for families, as well as help primary care staff to potentially advocate for families who might be at risk of child welfare system involvement because of biases or misperceptions. Next slide, please. As Kamala described earlier, we conducted key informant interviews and a small group convening for this project. And participants in those meetings highlighted that time and resource limitations are really the main barrier to primary care practices providing comprehensive care that can help to prevent child welfare system involvement. And so we identified 3 strategies that can help to alleviate these barriers and build out primary care capacity. So first, primary care practices can expand their care teams to include community health workers, peers, patient navigators, and others. And these care team members can play an important role in providing more holistic care for children and their families, including addressing needs that are related to child welfare system involvement. Community health workers and peers can also increase cultural competence and humility. And so incorporating these roles into primary care practices may help to reduce bias in reporting to CPS. A second strategy is to leverage tools that can help primary care practices improve efficiency. This can support effective care by providing more time for families to discuss their strengths and needs, and to build trusting relationships between providers and families. So for example, tools that allow families to submit information prior to a visit can help to focus the in-person visit on families' priorities. A third strategy is to implement training to improve primary care staff's competencies and skills to address risk factors and promote protective factors. So this might include training in behavioral health and relational health and health-related social needs. And training can also help to reduce unwarranted CPS reporting by focusing on topics such as implicit bias and roles and responsibilities of the child welfare system and mandated reporting requirements. Next slide, please. This slide just covers a few examples related to the strategies I just discussed. So first, the Safe Environment for Every Kid, or SEEK, is one example of a model that provides training and resources for primary care providers to identify and address risk factors associated with child maltreatment. And during the panel discussion, Dr. Teresa Fuller will speak to her experience with the SEEK model. And the second text box includes just a list of example training topics that primary care practices can consider. Next slide, please. So I'm now going to cover the 4 recommendations that we developed for state Medicaid agencies to support primary care practices in implementing these strategies. These recommendations are focused on payment approaches, managed care, workforce capacity and development, and collaboration. Next slide, please. So the first recommendation is to implement primary care payment approaches that support integrated, equitable, team-based care and child and family well-being. And I'll just focus on 2 of the points on this slide. Many children and their families face challenges in accessing behavioral health services because they don't have a formal diagnosis, and without a diagnosis, providers typically can't be reimbursed through Medicaid. And several states are moving away from these diagnosis requirements and allowing services to be provided to children and their caregivers to prevent behavioral health needs and support relational health. And California is one example of a state that's done this and has gone even further to implement a dyadic services and family therapy benefit, which Dr. Kate Margolis can discuss further during the panel discussion. Many state Medicaid agencies have also implemented new approaches to cover services to identify and address health-related social needs. So for example, the Centers for Medicare and Medicaid Services recently issued guidance that supports states in using 1115 demonstrations to cover services for these needs. So this is one important opportunity that several states have taken up. And these approaches can help to prevent child welfare system involvement by mitigating related risk factors and expanding the network of community-based services that primary care practices can refer families to. Next slide, please. Our second recommendation is to use Medicaid managed care contracts to prioritize primary care quality improvement for children. So this includes setting higher benchmarks for managed care organizations related to providing high quality, comprehensive care for children and their families, and implementing performance incentives. And one example of this is Oregon's incentive measure related to social emotional services for children, which Colleen Rulin can speak more to during the panel discussion. This can also include using measurement and incentives to improve equity and reduce disparities in children's health. And states can also implement other contract requirements, such as those that require managed care organizations to train primary care providers and staff to support more comprehensive care. Next slide, please. Our third recommendation is to support primary care capacity and workforce development to identify and address behavioral health, relational health, and health-related social needs, and to prevent unwarranted CPS reporting. So states can develop and implement training, technical assistance, and peer learning opportunities to help primary care practices provide comprehensive care, as well as increase awareness of the child welfare system, mandated reporting requirements, and implicit bias. So one example of this is New York's Child Welfare Agency, which provides training for mandated reporters that includes a focus on implicit bias with the goal of reducing unwarranted reporting to CPS. And the state Medicaid agency requires all enrolled home and community-based service providers to take that training. Next slide, please. Our final recommendation is to collaborate across Medicaid, child welfare, and other child-serving state agencies to align services, policy, and financing. State agency collaborations can help to advance shared goals and promote child health quality improvements. So one example of this is Ohio RISE, and that is Ohio's specialized Medicaid managed care plan for children with complex behavioral health needs. The state's Medicaid agency has led the development and implementation of this health plan with an interagency council that includes the State Child Welfare Agency, among other agencies. One key opportunity is for states to consider how to grade policies and funding to improve care for children. So this includes alignment across Medicaid and child welfare's Title IV-E funding, given that both of those funding streams can now cover various services related to preventing child welfare system involvement. So that's the end of this section. And as Campbell mentioned, this information will be included in a forthcoming report that we'll be publishing soon. Appreciate your time, and I'm happy to answer any questions during the Q&A section. And with that, I'll turn it over to Kelsey.
Thank you, Olivia. Hello, everyone. We're now going to transition to the panel portion of today's webinar. I'm excited to introduce our guest panelists. We have Teresa Fuller, who's a pediatrician at Main Street Pediatrics in Owings Mill, Maryland. I'm also excited to welcome Catherine Margolis, assistant professor at UCSF and director division of integrated behavioral health at the Department of Psychiatry and Behavioral Health Sciences at the Zuckerberg San Francisco General Hospital campus. And also happy to welcome Colleen Rulin, director of the Oregon Pediatric Improvement Partnership and instructor in the pediatric department at Oregon Health and Sciences University. Welcome, everyone, and so glad that you could join us today. At this time, I welcome all of our panelists to turn on their cameras. Yeah, you're all there. Excellent. Thank you, guys. So to help the audience get acquainted with you all, I'm going to ask that each of you kick things off by providing just a really brief overview of your work related to providing more comprehensive and holistic pediatric primary care. So let's start with Catherine.
Hi, everyone. Thank you so much, Kelsey. My name is Kate Margolis. I'm a child psychologist by training, and as mentioned, I'm a faculty member at UCSF in psychiatry and pediatrics. I lead our Division of Integrated Behavioral Health in the Department of Psychiatry at San Francisco General Hospital, which is our county safety net hospital. And that includes leading our integrated behavioral health programming in our highest volume safety net pediatric clinic there. As part of this work, and that includes actually our Healthy Steps program, and as part of the work of our Healthy Steps program and looking to sustain that program, we led a dyadic billing demonstration project that really looked at removing diagnosis from in order to sustain our services, to be able to bill for those services. And that helped to inform the dyadic benefit in California. And so now as part of that work, I'm leading a technical assistance center to support the uptake and scaling of the dyadic services benefit within California.
Thank you. Let's now move to Teresa.
Hello, everybody. Good afternoon. And thank you for the opportunity to participate. Yes, my name is Teresa Fuller. I'm a general pediatrician with additional board certification in holistic integrative pediatrics. And I've been practicing pediatrics for the past 20 years. For this second half of this 20 years, I've really been focused on primary care. I've been working in a large primary care, medium-sized primary care practice, where, of course, the priority is on creating healthy environments for our patients. I really try to focus my families on healthy, eating, healthy environments, exercise, sleep, all of the basics of just a general healthy environment for our kids. And one of the things that our practice has implemented is SEEK, which I'll discuss further later on in this panel discussion, but a way to make sure we're truly screening, truly identifying and addressing some of the barriers to healthy environments of our patients. So thank you.
Thank you so much. And Colleen, welcome you to introduce yourself.
Hi there. My name is Colleen Ruland. I'm the director of the Oregon Pediatric Improvement Partnership and super excited to be here as well. Our organization has an aim to improve the health of all children in Oregon through developing and supporting collective impact models of improvement. So what does that mean? That means that we support and engage healthcare, particularly primary care, but that we take a population-based approach to those improvement efforts. So we work with primary care, but then we do a lot of work with the community and clinical settings that are needed for primary care to report out to. We do this through at the elbow support of primary care across the state of Oregon, which has some pretty rural parts. And so it's been really interesting to learn from that. And then because we're using a collective impact model, that means that we're working with community-based providers, parents to inform our work, and health systems. So the last part that we do a lot of work on is, as we're working with primary care, we have to think about the system that's perfectly designed for them to be in the setting that they're in. And so we're really focused on kind of how do you actually improve that system and what are some of the levers that can sustain the really innovative and meaningful work that we help to support implementation in primary care. So there's a component of our work that's focused on working with health systems on metrics and payment methodologies that can incentivize the very kinds of improvements and services that are implemented and identified in our projects.
Thank you so much, everyone, for all those introductions. I'm really glad to have you here as experts and reactors. So, your key findings from our project, as Olivia explained, is that addressing things like social needs, behavioral health, and relational health needs are really important factors for reducing risks for child maltreatment and ultimately child welfare involvement. To that end, I'd love to hear from you all. What opportunities are there from your perspective for practices to address these needs? And let's start with Colleen.
Thanks. Well, first of all, the largest proportion of children child welfare involved in our state are children birth to 5. So primary care plays a critical role in the first 5 years of life, given that's where the car seats of young children are parked. And if you just think about well visits, there are 15 opportunities in those well visits to build strength, focus on attachment, and address the triggers and behaviors that may lead to a context and setting that would put a child at risk for child welfare involvement. So we've been working with primary care practices to transform their care to address these root causes of health inequity. Many of those factors that Olivia mentioned are factors related to family social complexity, and that family social complexity then impacts attachment and early relational health. So some specific opportunities that we've been working with primary care is one, in supporting enhancements to their integrated behavioral health that are actually focused on birth to 5 and emphasize relational health and emphasize dyadic care approaches and child and family supports. What we found is that if primary care practices have integrated behavioral health, they're often generalists that focus on school-age children with a diagnosis. So I'm loving Kate's work in terms of like, how do we go further upstream and think about that role that integrated behavioral health can play for children birth to 5 based on the clues that primary care has. Primary care implements a lot of Bright Futures EPSCD screenings that actually are clues for you of potential risk factors for child welfare involvement or potential risk factors for lack of attachment that could lead to some of those poor outcomes. We've also been working with primary care to address the risk factors in terms of thinking of that as like the health of the child. I think a lot of primary care providers are unaware of their primary causes. In our state, with almost like an 85% accuracy, children whose parents have been incarcerated, substance use disorder, or mental health are likely to be child welfare involved. So we've been thinking about like, how do you make a trauma-informed primary care setting for those families? How do you use a strength-based approach to making it safe for them to disclose those kinds of factors and be able to get those supports? And then lastly, we've been working with health systems and communities on supports that are needed for primary care. So should primary care do this early identification, brief intervention, they are going to need to refer out. And so we've been really thinking and working in communities about, do you have specialty providers that see birth to 5? Do you have specialty behavioral health providers that address ACEs? What does it look like in terms of family-centered pathways for primary care to get families to those settings? If we know that racism is a primary predictor of child welfare involvement, do we have behavioral health providers of color that families of color would feel comfortable going to? And so those are some 3 key areas that we've been working on in terms of helping support primary care practices in their role to prevent child welfare involvement.
Great, thank you so much, Colleen. Let's go to Teresa.
Yes, and Colleen, I thank you for those comments because definitely in a primary care practice, there are a lot of opportunities, but a lot of barriers, as you pointed out. And so I think one of the main advantages that we have as primary care physicians is that we have that frequent interaction with patients, we have those frequent touch points, and we have a long-term relationship with the patients. And so it does give us the opportunity to, number one, to build trust. As patients are coming to us, as families are coming to us, they are trusting us with, the information, their needs, their challenges, and so we're often having to address those things. And so I think just the nature of primary care does give us some unique advantages. They're also looking to us, they're expecting us to have that information, to have guidance, and to have some resources for them in all of those areas, not just physical health, but also their behavioral and their mental health, relational health issues that they're having. And we're seeing those every day. And so I think that in our practices, we have those opportunities. We have to take advantage of them because even though we're seeing them, if we're not making sure that we're using some kind of system to identify what those barriers are, sometimes even though our families may trust us, they still may not think to bring them up. And so I think just having the ability to identify and then link them with those resources are a great advantage.
Great, thank you. And Kate, we'd love to hear your thoughts.
Thank you. I wanted to focus on two aspects of also the primary care setting. The first is, of course, introducing, as mentioned in the report, team-based integrated care programs that really have an upstream approach, as upstream as possible in child development, starting at newborn visits, starting at prenatal visits when that's possible. This might include behavioral health specialists, community health workers, other classes of providers. And some of the things that this will allow for is a shift in focus from individual to family-based care, which is something that family medicine settings tend to do well. Pediatric settings can struggle a bit more with. We are always looking at environmental health, and yet it's hard to know how to weave in the support to families in the moment during well-child visits. And there are models that are designed to support this. This is something that does not come intuitively for our healthcare systems that have historically been reactive and looking for pathology before we are intervening. And so, this is how we can begin to engage families in a way that feels supportive, that is really focused also on building trust. And then, of course, building in payment mechanisms that support these services. So I think there was a question in the Q&A around how can we look at, removing a DSM traditional diagnosis. And yes, it is about looking at what can be paired with Z codes, leveraging EPSDT benefit to do that. The second piece that I wanted to emphasize is about this reflective practice kind of approach. And so this is about trauma-informed care and developing a clinic and a healthcare environment that structurally supports social, emotional, and relational health. And so, as we know, pediatric visits tend to be, last I checked, somewhere like 12 to 17 minutes on average. And so we don't have opportunities to pause and reflect and think about how bias might be being introduced into our care, and where in our care delivery system does it feel fragmented for families where transitions might be really difficult? Think about procedures or wait times that might actually be set up a ripe environment for families to feel stressed and become reactive. And then our care team members are stressed. And so I think creating an environment that supports those care team members to seek help and to feel confident doing that when they are stressed, so that we can prevent these kinds of interactions from happening, that then unfortunately end up oftentimes introducing bias and ending up with punitive consequences for families.
Thank you, everyone. So kind of actually going off of that last point you made, Kate, as Olivia emphasized up top, developing a more developing more comprehensive approaches to care, it really is essential to center health equity, as you were just saying, as a goal to ensure that transformation efforts, reduce and don't unintentionally exacerbate disparities in health and social outcomes. So I think all of you started to touch on this, but wanted to give you a chance to elaborate on what opportunities you see for primary care, really to center equity when implementing new approaches to care. And maybe let's start with Teresa this time.
Well, I think one of the major things is starting with awareness. As has been said before, just being aware of some of the biases and the racism that is already structured into a lot of the systems that we're dealing with, starting with being aware of that happening is so important. There's a lot of studies, there are a lot of studies that are coming out showing even, that the care can be different in when the care is given by, if there's a different race as opposed to someone who is of that same race or same cultural background, just that there's a sensitivity that typically is there. And so once we're aware of those biases, then we can not only, just assess ourselves, but also we can put in place training and different types of programs that will help us to be more aware of implicit bias. So for example, I know that there are more practices and more healthcare systems are implementing some of those implicit bias trainings. And I think that is a good first step. We have to recognize the resource depletion that is going to be in communities that have fewer resources. I mean, the resource depletion that are going to be in families who are of different of disadvantaged ethnicities, and just recognizing that helps us to make sure that we're not cutting them off from opportunities because they don't have access to, whether it's the technology, as the technology divide that was evident in the pandemic. So we have to recognize that and implement access to those resources. So I think those are some of the ways that we can help eliminate those barriers.
Great, thank you so much. Let's go to Kate.
Okay. I think, well, a few things. Number one, again, as was mentioned, we have to hire a workforce that is culturally and linguistically concordant with shared lived experience with our patient population. A lot of those folks are not in the licensed behavioral health clinician, right, have not had those opportunities to seek education like that, or are not MDs, and we need to get them in the pipeline. And we also need to expand the classes of providers that are able to be reimbursed as Medicaid providers. In addition to that, anytime we are developing new initiatives, especially around trauma-informed care in our clinic settings, is to incorporate family voices, community voices. That can be done via paid family leaders. Pediatrics Supporting Parents is leading an initiative that is really focusing on this. We have 5 proof point communities across the country that are integrating family leaders in this way. And I know that there are many other initiatives doing similar things. And then incorporating evidence-based, population-based approaches to integrated care, because part of what happens is we either under or over identify our kids, or we under or over refer our kids. And so having something that is more standardized, population-based, it helps to mitigate the bias in the way that we're identifying and referring families for timely services. And then, as I had mentioned previously around this reflective practice opportunities for that, this helps us develop templates and standard practices for how to talk about how bias manifests in care. become comfortable with uncomfortable, comfortable talking about how racism manifests in the clinic and how families are being treated in punitive ways because of how we are experiencing them. This can be done concretely through moments of pause. For example, what I think about so much are with our, families with infants, newborns who maybe have had a history of substance use or prior involvement with child welfare system. The way that if they don't come to a visit, the way that bias can become woven into the way that folks in the team are thinking about what to do next. And one of the things that we are so well positioned to do in primary care, and that integrating community health workers or behavioral health specialists can help us to do, is that part of that work that they are doing is about developing a relationship and prioritizing that piece, that alliance and trust with the family, as well as thinking about who else is in their village that we can engage, because maybe they didn't come to clinic, but maybe they were with another family member or a public health nurse who we can reach out to and find out more about that. And so it helps us to think about who else we can engage for help so that we're not working alone, which so much of the time in isolation can lead us to make decisions that are not going to be helpful for families.
Thank you. And Colleen, welcome your thoughts as well.
Thanks for letting me share. I really strongly believe that if we're going to address health equity, we need to focus on children that have health complexity. So health complexity is a concept that takes into account that they have medical complexity, but it also takes into account social complexity, which are factors that are associated with evidence of higher costs, and they're also factors associated with adverse childhood events. Those same factors are associated with child welfare involvement. So I think that we can't achieve health equity if we don't actually prioritize metrics and strategies that take that combined story together. I have some concerns that the way we're going to get there is through screening in primary care, given the context that primary care is a mandatory reporter, and in having parent advisors tell us about the trauma of going into those settings. So we've been really focused on how do you actually use data that we already have, rather than putting that burden on that family to go in and get screened. And so we've been doing a lot of work about how do you actually leverage cross-sector data at the state level that quantifies medical and social complexity. Interestingly, that kind of forces a collective impact model. If you force the systems to share their data, you might force the systems to work together, which is what we're saying the ground level needs. So for example, in our state, we do understand the proportion of children in Medicaid who have medical complexity and have social complexity predictive of child welfare involvement. So what proportion of children in Medicaid have a parent who's been incarcerated, a parent who experiences substance use disorder, parental mental health, or past foster care involvement. And so having that population data then helps us understand how we might create better systems and better metrics that allow us to stratify those metrics for those most vulnerable populations so that we can prioritize the health equity in that way. Within a primary care site, I think, leveraging that data, but then thinking through trauma-informed and strength-based interventions that really kind of think about, like, if you have these common disruptive behaviors, how would you think about, for these families that are health complex, what might be the best culturally and linguistically appropriate services, taking into account the trauma that NAs would have in terms of what they bring into that environment?
Well, thank you so much. So now I'm going to ask a question. This one's for Teresa. So Olivia described in her presentation that, one example of a specific intervention that can help reduce child maltreatment is SEEK, which stands for Safe Environment for Every Kid. So I'm curious, Teresa, if you could tell us more about the SEEK model and what motivated your practice to implement it.
Yes, the SEEK model, as you said, stands for Safe Environment for Every Kid. It's a screening tool that's pretty easily incorporated into a well child visit. And so the way I practice first heard about this some years ago, I believe just before the pandemic, or may even have been during, but we were introduced to this model, in which basically what it does is it's a questionnaire, and it basically asks parents to identify some of these environmental hazards that children may be exposed to. And what makes it so helpful is that oftentimes when we're in a well visit, I think all of us as pediatricians, we ask general questions about safety, but it's very easy to overlook one thing or another. You're more likely to, you're going to ask certain questions, and you may forget to ask about, one safety hazard as opposed to another. So the SEEK questionnaire covers everything. It's very easy for parents to fill out. It asks about physical safety issues, such as smoking, smoke detectors, things like that. But more so, I think what's even more significant is it does ask about things such as maternal depression, or questions that get at maternal depression, household substance abuse, disciplinary issues. And so it's when the patient is first coming in, the way we implement it, the patient comes in, the parent fills out the questionnaire, and then we receive it before the visit, and that gives us an opportunity to just know what we may need to address. We realized that we were probably, although we focus on safety, we were probably not capturing all of the risks to our patients' situations. And so I think that it's been very helpful. One of the things that the SEEK model does is, in addition, obviously, identifying is just the first step. The next step is that we want to address what we find. So when we find a positive SEEK situation, such as a positive environmental problem, such as maternal depression, one of the things that's really good about it is that we were able to also implement or create a list of resources. And this is something that was done by the social worker with the office that we're working with. And so they were able to give us resources for our area. And I've had multiple opportunities to use the tool. I would just like to illustrate it with one specific situation. I had a parent who revealed on the questionnaire that that she and her partner were fighting a lot, that she had been threatened by her partner. And these are questions that are specifically on the questionnaire. And so I don't know that I would have gotten at that without that questionnaire, would I necessarily have gotten that information. But it did open up the opportunity for us to discuss it. And I was able to get more information. I was able to then talk to the parent about how this affects the child's health, how that family stress, how those interactions between mom and dad were affecting the child's health. And then also able to give her actual resources of domestic violence locations in the area, so that she could contact them and get the help that she needed. And in addition to that, while we have those written resources to just hand the patient, we also have access to the social worker with the program, who we can get in touch with the parent as well. So I think it's really a critical tool for better addressing and identifying these environmental threats to our patients.
Great. Thank you so much for that. Yeah, really specific example. It's always helpful to hear kind of what that looks like in practice. So now I'm going to shift a bit more to the policy level with a question for Colleen and Kate. So, some key challenges for providers that we heard across the board is things like payment, time, and staffing constraints for implementing all the types of interventions that we have been talking about. So, Colleen and Kate, would love to hear from you about what payment levers policymakers may consider to better support providers serving children in providing more comprehensive care.
I'll go first, Kate. Is that okay? Okay. The first is Medicaid health systems. They use metrics, right? And what we've seen is the biggest way to improve is to use metrics that you then provide financial incentives for. And so that is why our organization's been focused on metrics for birth to 5. Again, those are top child welfare involved. And then are thinking about metrics that actually incentivize the kinds of behavioral health services that we're talking about. So in Oregon, we have the first ever metric that's a incentivized measure for the coordinated care organizations, which are attributed over 93% of the publicly insured children in our state. And that metric is a glide path metric that the first 3 years, they have to think about their provider network adequacy and then their payment and policies that would support social emotional services that address the very things I've been talking about today. There's a component of that metric that other Medicaid health systems could use. That's a child level metric about whether children receive those services. As I mentioned, the health complexity data, we're pretty lucky in that we're actually able to see overall what proportion of children have received a social emotional service, but we can actually look at whether children who have had those risk factors predictive of child welfare involvement received a social emotional service in order to prioritize some of that health equity focus. The second is to support enhanced payments for integrated behavioral health and primary care. There are some health systems that don't allow for behavioral health codes to be billed from primary care. That's a policy that needs to be addressed. For young children, again, they're most likely to be child welfare involved. You have to address the diagnosis. I saw some questions around that. In Oregon, the way we're addressing that is that Oregon does cover behavioral health services for children with at-risk codes that are aligned with the DC-5 diagnostic criteria. And then the last point I'll make, just because I want to make sure that Kate has time to share too, is how do we support medical homes? Primary care sites need to be medical homes in order to be able to do this type of team-based care. So how do we think about PMPM methodologies that support infrastructure overall, but PMPM methodologies that would support behavioral health for these kinds of children? And then how do you build in value-based payment methodologies that include metrics around the kinds of systems and supports, for example, social emotional supports that we're talking about? But Kate, I know we're limited on time, so why don't I pass to you?
Sure, thank you. Yeah, again, the work in California has been really about changing the way that we think about medical necessity so that we can provide reimbursable health promotion and prevention services in the realm of behavioral health, as well as in care management. And so I wanted to talk a little bit about the family therapy and the dyadic benefits that were mentioned earlier. And this is about leveraging the EPSDT entitlement that allows to pay for that requires providing preventative care services. And it's about paying for team-based care on the same day during well child visits. There are still concerns as it relates to federally qualified health centers because we do still have a same-day exclusion in California, but there have been some steps taken to remediate and make that more beneficial for practices. But starting with the family therapy benefit, this was opened in June of 2020 in California. It's a time-based code, and it essentially allows billing for family therapy with a Z code as a primary diagnosis. And it's developed off of ACEs science and what we know about risk factors that end up we seeing, kids and families with negative health outcomes as it relates to toxic stress. And so family therapy allows whether the child or the caregiver has had experience of discrimination, child with a separation from a caregiver with their own history of ACEs, or with a mental health concern to be able to provide the family therapy service. It also allows for couples to get couples therapy billed to the child's account if there is interparental conflict or something that is seen as being harmful to the child. And then the dyadic benefit covers 4 core services. One of those is dyadic behavioral health well child visits. Another is community supports, which also includes the care coordination and consultation among providers. Psychoeducational supports to families, so akin to what we would provide in terms of anticipatory guidance, and then family training. And so again, these can be provided along with well child care. I would encourage folks to look at the non-specialty mental health services provider policy manual in California that really details out all of these codes and how they can be used. And then the dyadic benefit was built off of the Healthy Steps model. And so just kind of considering how that's structured as something that could be a promoter to use.
Great, thank you both. And unfortunately, we don't have a ton of time for audience Q&A, but luckily, I thank the panelists for answering some of the themes in the chat. I'll run me through your answers to the previous questions. So hopefully we covered some of those topics at least a high level. One question that will probably be my last question here is one person in the chat just noted how, at their clinic, they offer some of these types of services that we've been discussing, but their challenge really is family engagement. Families don't often want to pick up these services. So curious if anyone can speak to any sort of strategies or approaches you've used or think might be promising to overcome that challenge.
I'll chime in. I would just say this is really, it reinforces needing to take advantage of the opportunities when families are there and when they're open, and not generating a referral that would then require families to come back and seek a supportive service. We know that pediatricians are the second most trusted person for families. And so being side by side with that person goes such a long way. When motivation is high, when families are exposing vulnerable details about their lives, it's so critical to have somebody already there with you.
A lot of sense. Thanks for that.
Yes, and frequent follow-up, I think also, I find the same thing, that oftentimes I'll refer a family and they may not have contacted the resource that we gave them, but sometimes it's just those couple extra times of following up, or whatever I can do to facilitate it. So if we have some extra staffing in the office who can make that handoff happen a little more warmly, sometimes that helps too. So, but yes, that is a constant barrier, I find.
I guess the only thing I'll add, and the reason I kept using strength-based, is I think families aren't engaged when you're telling them what you think they need. And so when I say strength-based, what I mean is, how do you start with the opportunity and the strengths that are in the family, and then where do they want to focus? I think engagement often happens because we have a set agenda for them, as opposed to recognizing that our systems and supports don't work for them. And so the solution isn't fixing them. Our solution is fixing our systems and supports to better meet their needs. And so I think some of it is that foundational paradigm shift of how we provide supports to families.
Thank you all for those answers. And with that, I see we're about at time, so we're going to have to wrap up. Apologies, I couldn't get to more audience questions today. But thank you everyone for your participation and for joining us. And thank you again to all of our panelists for sharing your insights. We really appreciate it. And finally, I also wanted to thank the Conrad and Hilton Foundation once again for supporting this work. As a few takeaways, I just want to encourage folks to keep an eye out for our report on this topic, which will hopefully be published in the coming month. And also encourage folks to fill out the evaluation that will pop up on your screen after this event. We really value your feedback to help us plan for future webinars. And with that, thank you so much and have a great day, everyone.